Okay, I don't really think I need to introduce Bea, and we all are aware of what's going on with your medical practice being affected by people that don't understand the issues. So let's go ahead and talk a little bit about it.
All right, well, move that down a little bit. So when Dick asked me to talk about this, I said, sure, I'd be glad to talk about it. Actually, do I need the microphone now? I didn't. So it's something that you'd have to be living under a rock not to know there's some big issues with opioid crisis right now, right? Anyone not know that we have problems going on? All right, so we've got some objectives. I love opinions. And I have coach. All right, so anyway. So where are we right now? This is the 12th of January 2018. Besides sitting in 3322 in the med school. Well, according to the best that I can find, about 100 million people have pain every year. So someone in here has had pain. Today, yesterday, whatever. Of those, about 10% have chronic or persistent pain. This is non-cancer pain. We're talking about things like osteoarthritis, low back pain, things like that. Okay, so not cancer pain, other things. The CDC says that about the annual prescriptions for opioids are equal to the number of adults in the U.S. Anyone have an idea how many people that is? Anyone take a guess? There's no penalty for guessing.
400 million?
Oh, what, 3.3 million?
Now, how many adults are there in the U.S.?
Oh, adults.
Adults.
Does that include the president?
50 million people.
How many?
Let's say 200 million.
200 million? Tyler? 125. Anybody else want to guess? 245.3 million adults. So 245.3 million prescriptions for opioids are written every year.
That's crazy.
That is amazing. So everybody in here has got a prescription for opioids. You guys didn't know it. Okay? All right, so more than 42,000 people died in 2016 from opioid overdoses. 40% were for prescriptions. Wow. Louisiana had a 14.7% increase in drug overdose deaths from 2015 to 2016 according to CDC. As I was walking to clinic yesterday going through the ER, they had 2 ODs coming in, both of them who were unstable. So, I mean, that's like, and we don't have the biggest increase. Missouri had more than a 30% increase. Illinois more than a 34% increase. Wow, that's huge. And, okay, this is even more amazing. You guys ready for this? More than the number of people who died from car crashes last year.
Wow.
I was floored by that. There were just under 38,000 people who died from car crashes. More than 42,000 died from ODs. Wow. Anyone have an idea that's not a huge problem? Now, you guys are P's, right? So you might think that's not a problem for me, which is not true, right? All right, so how did we get here? How did we wind up where we are in 2018 with this huge problem? Well, you know, we had to kind of go back to the beginning, all right? Because man has used substances since we climbed out the primordial ooze. We like altering the way we perceive reality, okay? And we use it for millennia. The first guy who plucked the coca leaf off the plant and chewed it and helped it being tired from working or whatever, oh, that feels pretty good. Let's keep on using that. It's been used for religious purposes, medicinal purposes, recreational purposes, okay? So we are kind of hardwired to want to feel good. And if you don't feel good just on your own, there's something out there that can make you feel that way, right? So, something to think about is how accepted the use of the psychoactive substances really depends upon how deeply embedded in the culture it is. So, for instance, the New World, the things that we use, tobacco, which is nicotine, and coca, which is cocaine, okay? So, in South America, using coca leaves, very well accepted. You know, they do it all the time. Do they get addicted to that? Probably that has potential, but it's not the same degree as with crack cocaine. Old world is things like hemp, which is the source of cannabis. The poppy was opium, and then alcohol, which, believe it or not, was really not known in North America before the advent of the Europeans, which was really devastating for Native Americans because they hadn't been exposed to alcohol, and the rate of alcoholism in Native Americans is extremely high. All right, so, well, the poppy was probably initially cultivated by the Sumerians more than 3,000 years ago. Okay, so we're talking about 5,000 years. Okay, that's a really long time to think about it. And they used it to help quiet crying children. Now, you teach people don't know anything about mom and dad giving the baby something they can sleep, right? Just please let me sleep. Helen of Troy, actually, in the Odyssey, they talk about how she put something in wine to help comfort the warriors in the Trojan War. And then laudanum, which is a tincture of opium, was really used extensively in the 19th century because it was cheaper than gin. And gin was a cheap alcohol that the working mass used to drink. So here you are, you're drinking tincture of opium to make you feel better. Okay? So we all use psychotropic medication. Who in here hasn't had caffeine today? Standing back there drinking her Dr. Pepper. I had a Diet Coke, a cup of tea, and iced tea this morning. Oh, I had a coffee too. Anyone here not have caffeine today? So caffeine use is ubiquitous, especially in our culture. But so is tobacco use, although it's not quite as widespread as it used to be. But we still use tobacco, and most people drink. Many people drink it, socially or otherwise. And they have really mild psychotropic effects. Okay, who cannot get up in the morning without some sort of caffeine? How many monsters do you drink in the morning? Too many. So we all use them, okay? Are any of us addicted to them? Probably not. But you would miss it if you didn't have them, right? But we can't not tinker. We always want to invent a better mousetrap. We always want to have a bigger, faster, more intense experience. And so we devise new and better strong formulations to get high, faster, and with less work. So, for instance, when you get that access to the brain, you get a stronger effect that doesn't always last as long. So think about it. When distilled liquor came out, okay, so before distilled liquor, we're talking about whiskey, scotch, all those other kinds of things. Beer and wine have relatively low amounts of alcohol, usually less than 10%. Distilled liquor is 50% alcohol. And look at this. This is AWOL. This is not a way without liquid. This is alcohol without liquid. This is aerosolized alcohol that you suck in and goes immediately to the brain. No drinking involved, okay? I think you still get drunk. I don't get hungover. But so you don't even have to drink it. Crack cocaine, when it came out, you smoked it in instant access to the brain. You got high really quickly, very addictive. Heroin, same thing, was not supposed to be addictive. It was supposed to be a safe way to use opium. Nah, not so true. And cigarettes, so before the advent of cigarettes, people, they chewed tobacco, they did snuff, they smoked a cigar, which they don't really inhale. The same thing with pipe tobacco, they didn't really inhale it all that much. Cigarettes, when you inhale cigarettes, you get that nicotine immediately to the brain, and you get an infection there. All right? So, we've used substances since Alexander the Great probably developed alcohol use. Aristotle talked about alcohol withdrawal and how drinking during pregnancy was dangerous. Aristotle. And Celsus, who's a Roman physician, said that dependence on alcohol was a disease, so it's not a new thing. All right, it's been around for millennia. It's been an issue for years, for centuries. This is not a new issue. This is not the first opioid epidemic that we've had. So back in the 18th century, the 1700s, the Chinese really got into smoking opium. The Chinese brought it to the United States. That got to be a huge problem, especially on the West Coast. Alcoholism for the working classes during Europe at the same time was a huge issue also. They were trying to escape the misery of their life. There was a huge opioid epidemic back in the late 19th century, late 1800s, with the use of laudanum. I mean, you could go and buy it in the store. You didn't have to have a prescription. It was very, very regulated. Physicians prescribed it widely, and until they really realized the deleterious effects of it, and decided to do something about it. All right, so I am not a neuroscientist, so this is very basic brain chemistry, okay? 101. So whatever drug you're talking about that you're using, it's some kind of an action reward center. It makes you feel good. It makes you want to do it again, right? So that it actually winds up conditioning your brain to interpret the signals the drug gives you as being biologically rewarded or potentially salient. So just like food or sex, okay, you have to eat to live, and our biological imperative is to reproduce, so having sex is also an important thing for most people. So you get those same kinds of rewards from these drugs of abuse as you do from food or sex, okay? You also, there are cues that are associated with using these drugs. So, does anybody here smoke? I don't just think about it. I'm not pointing fingers. So, when you talk to people who smoke, who stop smoking, people who used to drink, they'll tell you, the hardest time I have is, especially for smokers, first thing in the morning, a cup of coffee, newspaper, cigarette. Or after a meal, you know, a cup of coffee and a cigarette. Or if you are someone who drinks, you know, a cigarette with my drinking, with my alcohol. So those cues sometimes actually can trigger the craving for that substance, even if you've been abstinent for a long period of time, okay? And those cues can trigger the cravings because they act in places in your cortical limbic region saying, I need a cigarette, I need some cocaine, I need some heroin, or whatever it might be that you're addicted to, okay? So to be addicted, you have to have chronic exposure to the drug. Taking it one time is probably not going to addict you, unless you're really, really, really unlucky. And it tends to be more likely certain times of development. Adolescence is an excellent example because your brain is changing so much, you're more likely to get addicted if you're exposed when you're an adolescent. Especially adolescent girls with smoking, much more likely to become addicted to nicotine than adolescent boys. Same thing for other drugs that are abused. It's more than physical dependence. Everybody who is on narcotics for a certain period of time is going to develop a physical dependence. Your body's going to adapt to a new internal environment. That's true for everybody. If I stop giving you that medication, you're going to have withdrawal symptoms, which are unpleasant, but not life-threatening. That's not addiction because you have a psychological need for the drug, okay? People who are addicted have physical dependence, but people who have physical dependence aren't necessarily addicted. It's important to keep that in mind, all right? And it causes disruption in areas of the brain that are really important for motivation, reward, and inhibition. And it's really a brain disease. It's dysfunction of your brain tissue. So you need to think about it like that. And just as if you had someone who had coronary artery disease, and those are diseases of the cardiac muscle, it's the same kind of idea. Okay, this is a disease. This is not a weakness on your part. You're not morally decrepit. You have a disease that you really can't help sometimes. And sometimes you're really unlucky. About half the time, you've got some really strong genetic influences saying, okay, you are predisposed to becoming addicted. The other 40 to 60%, depending upon the resources you look at, have to do with your environment. Certain environments tend to be associated with greater degrees of addiction. Lower socioeconomic and more poorly educated populations. That's not to mean that people who are well educated and who are wealthy don't become addicted, because they do. But because of the situation that people who are poor, underprivileged, and underrepresented, sometimes they're trying to escape their circumstances. All right? Kind of makes sense. All right, so when you have addiction, you have intoxication initially with the drug. It has to be habit-forming, and you develop a tolerance, which means that it takes more to get the same effect. So if you are, I have no idea how you go out and buy this stuff, but say you're going to go out and buy some heroin. Let's talk about Lortab. I know that bit. So you're going to get addicted to Lortab. You take one Lortab tablet a day, you feel pretty good. And then, I don't feel so. I'm not getting the same highs until you're taking 2 Lortab tablets. Then you're taking 3 and 4 to get the same effect, because your body adapts to that particular concentration of drug in your bloodstream. You have a craving for it. You have a compulsive behavior wanting to get whatever that drug is. There's an addiction memory. When you don't take it, you withdraw, which is unpleasant but not deadly. And even if you want to be absent, you're still at risk for relapse. Okay, even though you don't want to use the drug, sometimes your brain actually makes you use the drug. You don't have a choice. And your behavior is reduced control because of those centers taking over. So even though you have negative consequences, okay, physical consequences like, especially if you're shooting up, you're getting skin ulcers, you might get endocarditis from your dirty needles or whatever. You lose your job, you lose your family, you lose your house, you're down on the streets, whatever. So even if you've got these really negative consequences, you still cannot stop using the drug. Some might get started by something, whatever it is, by changing your mood. So gambling is a good example. Somebody says those are also addictive things. So you go and you play blackjack and you win some money. You feel pretty good about that. Or you go out and you feel kind of crappy, take a look at you feel better about that. So sometimes just the mood change that you get with whatever that behavior might be can be the beginning for that tumble down the hill. And in the beginning, you've got positive conditioning. You take the drug, you go gamble, you have sex, shopping, happen to be addictive, right? You feel better. You do it again, you feel better. So that positive conditioning eventually turns into negative conditioning. But you still continue to use that drug because you can't not do it. All right, so now opioids bind to your mu-delta receptors. They mimic your endogenous opioid peptides, your endorphins, your enkephalins, your endomorphins, your dinorphins. And the mu receptor is one that's essential for rewarding behaviors when you use heroin and morphine and their analogs. So when you block that mu receptor, you don't get those people will not self-dose. They actually do this with rats in the lab. So if you block the mu receptor, you don't self-administer. So this is the thinking behind things like Suboxone, Subutex. You've got that narcotic, that mu antagonist along with the endorphin that keeps you from having withdrawal, but you don't get the reward from taking the drug. You have neural inhibition in the cortical pallidal and striatal circuit, which is where GABA, glutamate, and acetylcholine are inputted, and they have a really high density of opioid receptors. Okay, so it's just like long time what you would believe. All right, so there's the perfect storm. How did we get here? So that's kind of like the backstory. Now, there's probably only 3 people in this room who are going to know what they're going to talk about, because everybody else has lived it. All right, so the fifth vital sign. Sandy and Dick and I all remember when this came out. We've been around that long. But back in the 1980s, the American Pain Society began to be worried about the number of people who had chronic and persistent pain that was not being addressed. And they really pushed adding pain assessment as the 5th vital sign. And that actually got implemented. Drug Commission and the VA picked it up later in the 90s and said that you really had to assess for pain for patients, and if you had to give them something, you had to go back and reassess whether that pain medication effective. Drug Commission denies that, but that's not true. So they're good intentions because pain really is a very unpleasant thing to feel. Has anyone here in here not had pain at some point in time? Yeah, we've all had pain. That's not a pleasant sensation, especially if you have chronic pain or if you have really severe pain. All right? So it was good intention, but didn't do what they wanted it to do. So what is a sign? Well, a sign is something objective. It's something that you can measure. It's quantifiable. Your blood pressure is a sign. Your heart rate is a sign. Can you quantify someone's pain? No. It's whatever the patient says it is. You cannot measure it quantitatively. So it's whatever the patient says it is. And I wish I had a probe that could stick into someone and says, okay, Tyler, your only pain's a 2. You're not hurt. You're just being a weenie. All right? So I would love for us to have some objective way to measure pain, but we don't have that, and I don't think we ever will. So the unintended message that we gave patients was that you shouldn't hurt. That your goal should be pain-free. And when I ask patients, I run trauma service, so I see patients all the time who say, oh, I want to be pain-free. Well, 2 broken arms, 2 broken legs, and a broken pelvis, is it reasonable to think you're going to be pain-free? No, it's not. So they thought it should be pain-free, and it led to the expanding use of opioids for chronic and persistent pain, non-cancer pain. Now, I think the only people who should truly be pain-free are people dying from cancer. We should, our goal for them should be as close to pain-free as we can possibly get them. But everybody else, that's not my goal for you. My goal is for your pain to be tolerable, but not pain-free, all right? But we tell people, you should be pain-free. So now we have patients who come in, frequently who want medicine because they want to be pain-free, right? You guys, did anyone disagree with me? Yeah, all right. And the safety was touted, there was very little risk of addiction using pain medication for pain. So if you had chronic pain, and you were getting opioids for that, there was very little risk for addiction. Well, the studies were flawed. They were very small sample sizes. The longest one went 6 weeks. Wow, 6 weeks. So you have somebody who comes in, and we see this all the time, who's been on Norco 4 times a day for back pain for the past 10 years. Do they have problems with addiction? Oh, yes, they do. So, and here's the other thing. Some studies actually showed the opioids worsened both pain and patient functioning. So it not only did not make them better, it made them worse. Wow. So about the same time, the late 90s, early 2000s, Purdue Pharma came out with OxyContin. Okay, remember that bit? Came out with OxyContin, marketed for persistent chronic pain. Was not supposed to have a high abuse potential. It was supposed to be safe. And what happened? There was this explosion of OxyContin use in the country. And people dying from it because, you know what? People are kind of stupid sometimes. So when you have something that is an extended release and you grind it up and you snort it, chew it up, or whatever, what happens? You get this amount of narcotics supposed to be released over 12 hours, being released initially, immediately, and you wind up with overdoses. Right? All right, so other things that drove it, patient satisfaction surveys. These are exit surveys that the hospital contacts the patient after discharge and says, how was your stay? How did we treat your pain? Were you satisfied with what we did? Did someone ask you about the pain? Did they take your pain seriously? And they grade both physicians and hospitals on how well they managed pain. Now, this is especially true for ER. So if you're an ER physician and you're getting bad grades on pain management, you potentially are going to lose money and maybe even your job. If you're a hospital and you're not doing a very good job, guess what you're going to lose? You're going to lose money. Because CMS is not going to pay you as much because you're not doing a very good job. So that, when you've got someone holding that kind of a gun over your head, what is your inclination to do? Is to give pain medication because you want to get a good grade, right? So is that helpful for patients? No, it's not. So, and by the way, Joint Commission says they never mandated this, which is actually not true. So, what are the negative consequences of opioid use? Well, obviously addiction is the biggest one because, it's certainly not for some people. It makes it really, really hard to manage acute pain episodes. So when I have someone who comes in who's been using Norco for the past 10 years, and they've got two broken arms, two broken legs, two broken pelvis, I'm going to have a really hard time getting their pain under control. And they've got acute pain. I mean, they can't not have acute pain. So it really makes it difficult to treat these patients. You've got hyperalgesia. I think this is absolutely amazing. So the opioid actually makes your pain worse. And when you get the opioid and have hyperalgesia, guess what? It makes the pain even worse. You cannot give the patient enough opioid to relieve the patient's pain when they've got hyperalgesia. And of course, death. I mean, that's the ultimate bad thing that happens when you have opioid overdose, right? Is you die from them. That's really not the one we have patients do. So what are we going to do? What are we going to do? Okay, so it's easier in some ways for pediatric patients because little kids tend not to be addicted, although they develop tolerance very quickly. And in the hospital, if you get them off the narcotic right back, they'll go into withdrawal, which is not what you want. Teenagers, high addiction potential because of being teenagers, right? And risky behavior active. So what do we do? Well, Should we give opioids for minor injuries or minor surgical procedures? In-house, maybe so. On discharge, probably not. If they come into the ER and they just, really act like they're hurting badly, then perhaps give them a 1 or 2 day supply of narcotics, but certainly not any more than that. Okay? And it's not that you're trying to be mean or ugly to to the patient, but the thing is that they shouldn't hurt all that much from a sprained ankle. Anyone in here sprain their ankle? All right, I turned my left ankle around in a circle, okay? And it doesn't really work that way. Did I get any narcotic when I did that? No. You know what I took? Aspirin, because this is before the days of ibuprofen. The other thing that is problematic is if you have unused portions of prescriptions, those are vulnerable to diversion. I had a patient in the hospital not too long ago. He was a fall. He had metastatic cancer, and he was on chronic pain medication at home, which was appropriate for him. And he had a family member who was taking care of him who stole his pain medicine on a routine basis. So, which is really, here your dad's dying from cancer, and you're stealing pain medicine. That makes you
Great person.
a pretty good person. If you have to give an opioid, give a low dose for a short period. I'm going to give you some medicine, pain medicine for 1 or 2 days, and that's going to be it. For most musculoskeletal pain, NSAIDs work better. But how does the narcotic work? It changes your perception. The pain's still there, you just don't perceive it anymore. All right? So, how about the person who uses opioids all the time? Patients that we see on a routine basis in the circuit. So, my aim is not to detoxify you. I'm not rehab. The idea of putting you through detox when you're in here with 2 broken arms, 2 broken legs, and broken pelvis is not my idea of a good time. So that's not what I'm here to do. Okay, I'm here to try and treat your acute pain, get you as pain relief as possible, and still be safe. All right, so you've got to meet whatever they're using. So if they're in a pain program, it behooves you to try to talk to either their pharmacy or their physician to find out what are they supposed to be taking. Because, when you're in pain medicine, they actually count your pills. If you're calling for a refill in pain medicine before you're supposed to be out, they know that you're using what you're supposed to be using. They also usually drug test you, make sure you're not taking anything else in the pain program. So find out what you're using and give them whatever that is. Whether it's methadone, oxycontin, MS-contin, whatever it might be, you give them that much. A lot of times I have patients who are taking ortabitone, and they're taking 1 4 times a day. More 4 times a day, and I give them something else on top of that for breakthrough pain. Because you got to meet that baseline need, and then give them some more. All right. If they're on long-acting opioids and they can't take it orally, don't want to push and put down the NG tube because that kind of negates the long-acting stuff. Something to think about is maybe a fentanyl patch might be a good alternative because you've got that long, no peak. So that's really what you're looking at, is no peak. The peak is what makes you high. And then you crash, right? I don't want you high. I want you steady. I also tend not to give people IV stuff. Zofran, Benadryl, Phenergan, nothing IV. Because sometimes that IV part is the thing that gets them high. PCA is a good option. Let them control their pain, okay? Even if they're just punching the button, sometimes just being able to punch the button can make you feel better. Because if you feel like you're driving the car, then you feel like you're in more control, right? When you're in control, things are better. At least for me. I am really good about sitting down and having a real frank discussion about the pain. So a few years ago, I had a kid who was on the Peace Corps. She was a teenager, probably in her mid-teens, had a broken leg, whatever, I don't remember how she got hurt, but they had a real time getting her pain under control. She was on PCA, and it just, I just could not understand why they could not get her off the PCA. So I saw her for the first time on a Friday morning. I sat down at the bedside. I talked to her mom and her, and she was able to take part of the conversation. And I said, you're not going to be pain-free. And her mom said, really? We thought there was something wrong because she still had pain. I said, no. Your pain should be tolerable, but you're not going to be pain-free. Your injury means, you're going to hurt some. That's normal. I discharged her that afternoon. So having a real frank discussion about what to expect, that you're not going to be pain free, sometimes is just as valuable as the pain medication. Having, acknowledging the patient hurts, acknowledging their drug issues, and telling them, I'm going to do my best to get your pain under control, but it might take me a little bit. Because you use medicine so much, I might have a hard time getting it there, but we're going to do our best. It's amazing how much that works. Okay? So, keep in mind that if they have opioid analgesia, giving them opioids actually makes it worse. Giving them more pain medicine doesn't help, it actually makes it worse. And so, it actually continues to be a problem. Even after they no longer use it, they get cleaned, it can still be a problem years later. Not only with hyperalgesia, but also with increased tolerance. So, you upgrade it with your levels in your brain, and they continue to be there years after you stop using the opioids. So what else can you do? Well, if you're in the ICU, ketamine's a good option. It works in a completely different way. It does not bind to opioid receptors at all. Unfortunately, there's no oral form of ketamine available in the U.S. There are other places. That would be a great thing to be able to use, because then you have a different option, something that works in a different way. I like NSAIDs a lot because they work on musculoskeletal pain much better than narcotics do. Keep in mind, patients who've got renal issues, that can be a real problem. So you don't want to send someone to renal failure, which we've done before. Also, keep in mind if they've got problems with bleeding, gastric issues, it can also be a problem with patients as well. For neuropathic pain, gabapentin and pregabalin can be helpful, as can the acute pain service. So if you've got someone who's got a broken arm, they can do a block. Can't feel your arm. You've got no pain from that arm. It's a wonderful thing as the patient feels so. So what my take-home message is that if anyone was sleeping, opioid use is rampant. And it's not just in the United States, it's all across the world, okay? So it's not just us. If you have to use narcotics, use the lowest dose for the shortest period. Tell the patient, I'm going to give you 2 days, 3 days, 4 days, whatever, and you're not getting any more pain medicine after this, if you're doing it as an outpatient. If you've got someone who uses it chronically and they're in the hospital, meet their baseline needs, because you don't want them running a withdrawal. And then give them something on top of that, that's short-acting, to meet their acute pain needs, okay? Having a really frank discussion with the patient family, I cannot emphasize how valuable that is. Because here's the thing. We all feel better if we are more informed about what's going on. If you're just sort of in the dark and someone comes in and doesn't want to tell you what's going on, it's much more difficult for you to deal with it, as it is if you've got someone who's really told you this is what's going on, what I'm planning to do about it, that sort of thing, okay? And remember, if someone tells you that they hurt, the only person who knows that they're hurting is the patient, okay? So you have to take them seriously. Now, I don't mean that you have to give the pain medicine, but you have to take them seriously and think about what else can I do that might be more effective than giving them an opioid, okay? Think about some other options if the opioids really aren't working. Think about telling the patient about rehab when they get out of the hospital and get over their acute injury or whatever, so that, the only person who can get them off of opioids is them. They have to want to get off. You can't do that for them. It's the same thing with an alcoholic. They have to want to stop drinking. If they don't, you can do whatever you want to do, but it's not going to be effective. So the patient has to want to stop. Once they've got that desire, they're going to be much more likely to be successful. All right, that's it. Questions?
AAP no longer recommends any sort of coating, like syrups of any kind. Like they've actually been almost banned for all people less than 18.
Yeah, but so what are your other options?
Well, and the problem is too in kids, you got to remember we have a lot of them who can die very quickly from the opioids for the genetic aspect.
Right.
So really, we use, Motrin and Tylenol are some of the best medicines we ever see for any injury, even in little kids post-op.
Right.
Like they usually don't even need any sort of morphine or anything else. Like Tylenol and Motrin are
little
really
kids
good.
don't know they're supposed to hurt.
Well, yeah.
They haven't learned that
Yeah.
yet. And so, and that's true.
Mm-hmm.
But what do I see? I see kids coming out of the ICU, all they have ordered for pain is morphine.
Our
Okay.
our PIC was a little different.
Okay, well, they're not going home on morphine, you know, and
It's-
so,
We get bullied into it.
we need something else, you know, whether it's a Tylenol, Motrin, whatever, you know, something that's going to be just even more effective than the other things.
It's important for you guys to know, especially for your kids, whenever you take them to surgery for general things, like even apples and things like that, like they don't necessarily need, I mean, Tylenol and Motrin works great for them.
I try to take care of kids.
I know you do. I know, that's why we know you so well. But
Well, and, you know, and so then that's also why we consult you guys, because, you know, you guys have the expertise.
Yeah,
I can do
exactly.
trauma with my eyes closed.
Oh, yeah.
But it's not
Yeah,
that.
of
But
course.
you guys have the kid part, we really appreciate it.
that was a good talk. Thank you. That was wonderful.